Hi, everybody. I think, do we have a quorum here?
Um,
I
but
think
almost.
I think we have all the fellows. Becca, Naya, Abby, Paul, Troy, I think we're waiting on. Jillian.
I'm here.
Okay, great. Okay, and then Brad's there. Okay. First of all, I apologize, you guys. I'm kind of sick, so I'm not like at my best right now, but I think that we will get through this. You have already learned about the neurobiology of circadian rhythms. You've learned how to evaluate circadian rhythms, sleep wake disorders from Dr. Arnett. And now we're going to talk about treatment. This is an interactive talk. Um, and also, I have a sore throat. So I'm going to get you guys to help me by calling on you to read some cases and answer some questions. Okay, so here's our outline for today. We're going to start with a review, then we're going to go over some case-based presentations so we can talk about how to treat circadian rhythm sleep-wake disorders, and then we'll go through some high-yield pointers that you can always refer back to. Okay, so first review question, what are the 4 circadian rhythm sleep-wake disorders that are due to either endogenous abnormalities or of the circadian timekeeping system or abnormalities of the circadian clock's ability to entrain to the 24-hour day? And I'll look for hand raises first. So what are the 4 intrinsic circadian disorders?
But if you could contribute one, you could still raise your hand.
Yeah.
So I can go. There's delayed sleep phase. There's early circadian
Which is,
rhythm.
what do we call the early one?
Geez, I'm blanking on the name. I know it's like morning larks.
Advanced.
Advanced. That's
Advanced.
it. Yeah,
Okay,
advanced.
so we've got delayed and advanced. Yeah.
Delayed, advanced. And there's what? Free running.
So free running, which
Non-24.
exactly.
Yeah, non-24.
Or sleep
and-
late for them.
And
Irregular.
Irregular. Yeah.
Regular, we got them. Excellent job. Okay, so just to go over these. So let me orient you to this picture here. So this is a clock going 4 p.m. to 4 p.m. The gray is the quote unquote normal or conventional sleep wake timing. The dashed line is where dim light melatonin onset would be in somebody with normal or conventional sleep timing. And the black inverted triangles where core body temperature minimum would be in somebody with normal circadian sleep wake timing. And then the other black bars are individuals with circadian rhythm sleep wake disorder. So this individual here whose sleep is 4 a.m. to around noon. This is our individual who we would believe is at risk for delayed sleep wake phase disorder. So these folks have to have a delay in the phase of their major sleep episode. So it's later than what's desired or required. And so when they try to sleep at the desired or required times, they have difficulty falling asleep at the beginning of the night and difficulty waking up at the correct time. Typically, this results in a truncation of the sleep period because we oftentimes have fixed wake times due to obligations, whether they're educational, occupational, social. And so people have truncated sleep time, sleepiness. And when we let these individuals sleep within their circadian phase at their preferred time, their sleep quality and duration are normal. And you guys already know how to diagnose this. Advanced sleep wake phase disorder. As you can see here, this individual is sleeping 8 p.m. to 4 a.m. So this is the person who would be at risk for this. So these folks have a significant advance in the major phase of their sleep episode. So their sleep tendencies occur earlier than what's desired or required. So they have difficulty with evening sleepiness and making it to bedtime. And then they often awaken earlier than desired. If they can sleep on their preferred or biologically preferred schedule, they'll have normal sleep quality and duration. Very important to keep depression in the differential for this because of the early morning awakenings. And with circadian rhythm sleep-wake disorders, as Dr. Arnett discussed with the diagnosis, the key with these is individuals have to have symptoms. They have to have sleep complaints, sleepiness, issues with their functioning, because otherwise, if you have delayed sleep-wake phase disorder and you do just fine and you work a job, or excuse me, if you have a circadian phase delay and you work a job that you can sleep at that time, it's not impacting your life, you don't have sleep symptoms, that's not a circadian rhythm sleep-wake disorder. That's just your chronotype and you're sleeping within that. Same with advanced, which this is typically when we see this because there's usually no penalties for being early to rise, right? That's very advantageous in our society. So these individuals might leverage that to their advantage and not have any sleep disturbances. So you have to have a sleep disturbance to have one of these disorders. Irregular sleep-wake rhythm disorder, that would be this individual here. So there's an irregular pattern of sleep with multiple bouts scattered throughout the 24-hour day. There need to be at least 3. So symptomatically, this causes insomnia because people are awake in the middle of the night, and daytime sleepiness because they are falling asleep during the day. Non-24-hour sleep-wake rhythm disorders, these individuals cannot entrain to the external 24-hour light-dark cycle. So their sleep-wake tendencies are based entirely on their endogenous circadian rhythm. Because the circadian tau is typically longer than 24 hours, there is an iterative delay or becoming later each day of the sleep period. So that would be this individual here. This is seen most commonly in individuals with light perception blindness, but is also seen in individuals who are sighted, as you've learned about. We often talk about this disorder linearly. You'll frequently see that picture where it becomes the sleep timing becomes later and later. But another way that you can illustrate this is with a sine wave. So the blue sine wave is oscillating with a period of 24 hours. The red sine wave is oscillating with a period of 25 hours. And what you can see is these two sine waves go in and out of phase with one another. And so individuals will sometimes be symptom-free in what's called their beat phase if their period of sleep tendency is aligning with the nighttime period. And so you have to kind of catch them at the right time to evaluate them and to treat them. And we think that this is due, as you guys learn, to either complete lack of photic entrainment stimuli, because again, you have light perception blindness, or there's a problem with integration of those circadian time givers, or a problem with the entrainment mechanisms, or potentially the circadian tau is so prolonged that it's outside of the range of entrainment, so it just free runs. Okay, with what period, so which means time for one cycle, or tau, does the central circadian clock tick? So I'll look for any hand raises here. So how long does it take for one circadian cycle?
24 hours.
It was 24 point something, 0.2.
Exactly right. So on average, 24.18. So you can round to 24.2. Exactly right. So the human circadian tau in adults on average is 24.2. How do we know this? So they can do experiments where they isolate individuals from time cues. So for example, a forced desynchrony protocol where they completely extract sleep from circadian rhythms, and then they measure the period of circadian controlled processes like cortisol secretion, core body temperature, and melatonin secretion. Very good. So how does the circadian clock tick? How is this 24.2 oscillation of the central clock maintained? By a genetic transcriptional translational negative feedback loop. And at the core of that loop are B-Mal clock, and those are represented by these green and blue circles here to denote the B-Mal clock proteins. Heterodimers of B-Mal clock bind to the E-box and promote the transcription of purr and cry. then purr and cry form heterodimers in the cytoplasm, translocate back into the nucleus, and then repress their own transcription. Purr and cry are then depleted, and transcription begins again just over 24 hours later. And the way this oscillation timing is maintained is because there's post-translational modifications to purr and cry. So example, phosphorylation by casein kinase epsilon and delta. And there's also these ancillary loops. Where is the central circadian clock ticking? And you can just unmute yourself and answer.
Is it the suprachiasmatic nucleus?
Exactly right. Do you know where the suprachiasmatic nucleus is?
The medulla?
So it is in the anterior hypothalamus. So suprachiasmatic nucleus, it's a paired nuclei. It's behind the optic chiasm. The way you can remember, so there are a lot of sleep-involved structures in the hypothalamus, as you guys are learning. And the way you can remember anterior hypothalamus is, I don't usually like mnemonics, but for this, it's hard to remember otherwise. So circadian, it has an A in it, an A for anterior hypothalamus, as opposed to the lateral hypothalamus, which is relevant for narcolepsy, which has an L, because the lateral hypothalamus is where the hypocretin cell bodies live. So yes, SCN in the anterior hypothalamus. So even though that's where our central clock is located, there is peripheral clock machinery and thus circadian oscillations throughout the body in all the different peripheral organs, or vast majority of the peripheral organs and tissues. And the reason that's relevant is so not only can you have misalignment between your central clock and the environment, and your central clock and the behaviors that you have, right? Because we're humans, we can override our circadian clock, but you can also have misalignment between your central clock and the SCN and your peripheral clocks. You can have misalignment between your behaviors. So for example, like eating in the middle of your biological night and your peripheral clocks, and there can even be desynchrony between organs and within organs. And this is likely why we see so many health consequences of night shift work, which is kind of the most dramatic explanation or dramatic way we can misalign the circadian clock. And we've had cancers, metabolic disorder, cardiovascular disease that have all been associated with night shift work. Okay, when does endogenous melatonin secretion begin relative to habitual sleep onset, or your body's natural fall asleep time? Anyone know?
Can't remember if it's 2 hours or 5 hours.
So it's 2 hours before. So before your natural sleep onset, that's when your melatonin begins to rise. Good. When is your core body temperature minimum relative to your habitual sleep offset, or your natural wake up time?
2 hours.
Yep, about 2 to 3 hours. Exactly right. Why do we care? You might say, I don't care. You should care. So in clinical practice, it's pretty rare that we measure objective circadian phase. So we have to estimate circadian phase from the habitual sleep period. And the habitual sleep period is when your body truly wants to sleep, not when you want to sleep or need to sleep. So the best way to determine this, so for adolescents or students, is when they're off from school in the summer. For adults, prolonged vacation or even the weekends, this gives us a better idea of the natural sleep time. And so for this individual here, this gray box is their natural sleep time, and it's 11 p.m. to 7 a.m. So they have what we would have expected for a normal circadian rhythm. The dotted line is melatonin secretion here. And so we can see dim light melatonin onset, or DILMO. And the reason we call it dim light melatonin onset is because melatonin secretion is suppressed by light. So this has to be measured in less than 10 lux of light. But we can see the onset, which can be defined in a variety of ways, 3 picograms per milliliter in saliva. Sometimes they take the average of the 3 low baseline daytime levels and then add 2 standard deviations. Sometimes they kind of fit a curve to this and they look at when the slope changes. But the onset is expected to be 2 hours before the natural fall asleep time. And then melatonin secretion peaks just about 3 hours or so before the natural wake up time, just prior to core body temperature minimum. And so we can go to our temperature. Our solid line here represents core body temperature, and we can see our peak is just before the onset of melatonin secretion. And this is the highest circadian alerting signal of the day. We also refer to this as the forbidden zone for sleep. And this is when our insomnia patients really like to try and go to sleep, which exacerbates their problem. So we see the melatonin secretion begin about 2 hours prior to natural fall asleep time. And then the core body temperature begins to plummet, reaching its absolute nadir about 2 to 3 hours before your natural wake up time. And that nadir of core body temperature minimum is also timed. That is your body's lowest circadian alerting signal. If you've ever heard people refer to 4 a.m. courage, that's likely where this comes from, because your alertness is so low here. And this dash line of sleep propensity, you can see it's highest in alignment with the circadian nadir of alertness, peak of melatonin, and lowest core body temperature. Okay, the reason that being able to estimate those objective circadian phase markers is so important is for treatment, because we are going to time our treatment based not on clock time, but based on circadian time. And because we don't measure that, we need to estimate it. The way we determine how a particular stimuli is going to shift somebody's endogenous circadian clock is with phase response curves. And this is a phase response curve to light. And so let me orient you to this picture here. So again, we're back to that habitual sleep time, not when you want to sleep, but when your body has its highest sleep propensity. Hours here are positive after the natural fall asleep time, and they're negative before the natural fall asleep time. On the y-axis, we have the direction and magnitude of phase shift. So positive numbers and up arrows indicate a circadian phase advance, or the biological clock is moved earlier in reference to the 24-hour day. The down arrows and negative numbers denote a circadian phase delay, or the biological clock is being moved later in reference to the 24-hour day. And this is in response to light. This was a 10,000 lux light for an hour, I believe, at these different time points. The crossover of light producing a circadian phase delay to light producing a circadian phase advance is timed in alignment with what? What time is this occurring here? So it's about 2 to 3 hours prior to natural wake time. So the crossover point between light producing a circadian phase delay to a circadian phase advance is timed along with the core body temperature minimum. And that's why we want to be able to estimate that. When we look at this very strong, very large in magnitude circadian phase delay, we see it's right around the time of your natural sleep onset. And what do people like to do then? They like to shine little miniature suns into their eyes, right? So this is one of the reasons, one of the many reasons that we recommend people stay away from LED backlit screens, particularly big LED backlit screens like laptop computers and tablets. You can see that the circadian phase advancing time of light, it almost goes through a big chunk of the daytime. So you're still getting benefits even a few hours after that core body temperature minimum. We can also phase shift the clock with exogenous melatonin. This is the phase response curve for 0.5 milligrams of melatonin. And again, we have our habitual sleep time here with the positive numbers being hours after our natural sleep onset, negative numbers being hours before natural fall asleep time, with the arrows up and the positive numbers indicating that melatonin dosed at that time would produce a circadian phase advance or move the biological clock earlier in reference to the 24-hour day. The down arrows indicate that melatonin taken at that time would produce a circadian phase delay or move the endogenous clock later in reference to the external 24-hour day. So we see if melatonin is given anywhere from 8 hours before to 2 hours before natural fall asleep time, melatonin will do what? It'll produce a circadian phase advance, with the phase advance being of the highest magnitude here, around 5 hours or so before natural fall asleep time. Melatonin that's given within 2 hours prior to your natural fall asleep time, all the way through the hours following your natural wake up time, produces a circadian phase delay. The crossover point between melatonin causing a phase advance to a phase delay is timed with what? So it's 2 hours prior to your natural fall asleep time. What happens 2 hours prior to your natural fall asleep time?
Dilma.
Exactly right. So DILMO is your crossover point between melatonin producing a phase advance to phase delay. You see this kind of lull point here where melatonin doesn't really make a difference. That's when your body has its peak melatonin secretion, right? And so giving it exogenous melatonin doesn't really matter. And then you see the largest magnitude of phase delay is in the hours following natural rise time. Good. Okay, so now we're going to go on to some case-based examples of how to treat these disorders so we know how to approach them in clinic. And I'm going to start. So Troy, you're at the top of my screen, so I'm going to have you start by reading the first case.
A 17-year-old male notes difficulty falling asleep at night for the past 3 years. Currently, he gets into bed at 11 p.m., but feels like he tosses and turns for hours. He will often snooze his 8 a.m. alarm. He is missing his 9 a.m. class. On the days he does make it to his 9 a.m. class, he nods off unintentionally. He will often nap during these afternoons. He gets a second wind around 10 p.m. and is very productive at night. Even if he makes it to his class and avoids napping, he still can't fall asleep when he would like. He can't wait until summer break as he feels great, and has no trouble sleeping when he can stay up until 2 a.m. and sleep in to 11 a.m.
Great, thank you, Troy. Okay, so this is his actigraphy. So we see each of these as a day. This is 6 p.m. here, this is 6 a.m., this is 12 a.m., and this is 12 noon. So we can see a sharp offset of activity, typically around 2 a.m. And it looks like activity typically resumes around noon, sometimes even later, 2 o'clock. Sometimes it looks like he might have to get up at like 8, 9 o'clock and do something. So very similar to the case. And what would we say this diagnosis is?
Delayed.
Delayed sleep-wake phase disorder, correct. Okay. So which of the following treatment regimens do you want to start? Do you guys want to throw your answer in the chat? I don't know if I can see it.
D.
Okay, D. Who agrees with D?
Agree with D.
Okay, everyone agrees with D, so let's go through why this is. D is correct. Nice work, guys. Okay, so this person is delayed, so we want to produce a circadian phase advance, and we talked about that light and melatonin, the circadian Zeitgebers, can do that if we time it correctly. So we know that light will produce a circadian phase advance if it is given after the core body temperature minimum, and melatonin will produce a circadian phase advance if it's given around 2 to 4 hours prior to DILMO or about 5 hours prior to natural fall asleep time. So in this individual, if he's sleeping 2 a.m. to 11, his core body temperature minimum is going to be what time? 9 a.m., right? So we want to avoid light before 9 a.m. So he'll be asleep most of that time, but also in the evening. And we want to have him expose himself to light after 9 a.m. and in the hours that follow. Melatonin dosed around 8 p.m. So his estimated DILMO is going to be around midnight, right? If he typically falls asleep at 2 a.m. So if you dose melatonin at 8 p.m., that'll be 4 hours before DILMO, and this will produce a nice circadian phase advance. It will get his minimum of circadian alertness out of the window for class and into the end of the desired sleep time. Very good. What are the wrong answers? Modafinil, yes, that could mitigate sleepiness. Zolpidem can help with insomnia in general, but these aren't going to produce a circadian phase shift. We do sometimes see these individuals developing a psychophysiological insomnia on top of the circadian contributions to prolonged sleep onset latency. So sometimes cognitive behavioral therapy can be helpful, but again, it's not aimed at producing a circadian phase shift. Melatonin at 2 a.m. and light therapy at, I think that was 3 a.m. would produce a circadian phase delay and not a circadian phase advance. Now, hi, Anita.
Hey, question, and feel free to, if you want to defer this until the end of your talk. I don't know how much time you have, but I think you did an awesome job explaining this as always. I notice anecdotally that sometimes there's some confusion between 2 hours, 5 hours, like when we're seeing people in clinic. And I was wondering if you could, in terms of melatonin and administration, things like that, I was wondering if you'd be able to review that again, because I see some heads nodding. It seems to me that sometimes there's a little bit of confusion about those time windows.
So dim light melatonin onset. So the onset of your body's own melatonin secretion begins 2 hours prior to your natural fall asleep time. When we look at what happens to people's circadian phase when we give them exogenous melatonin, we find that it produces the biggest circadian phase advance when it's given about 5 hours prior to the natural fall asleep time. But when you look at circadian research, they don't, like when you look at a research study, they're never going to say, oh, it's best 5 hours before natural fall asleep time, because they're typically going to be measuring dim light melatonin onset. So they're going to be referencing the dosing of dim light melatonin to DILMO, not fall asleep time. But if you really just quick and dirty, you're doing it about 2 to 4 hours before DILMO, which is going to be 4 to 6 hours before your natural fall asleep time. And that's where 5 hours comes from. So it's 5 hours timed before your natural fall asleep time. And I don't even, I mean, you'll see here some people reference, well, when do I give it based on desired bedtime? I feel like that's just throwing more numbers in there. Like, just keep to what we know biologically, which is we want to know the natural fall asleep time, because the response to the circadian Zeitgebers is based on objective circadian phase, not the clock on the wall time. Does that clarify your questions, guys? Good. Okay.
I see heads nodding, so thank you.
Ready for clinic. Okay. Excellent. Very good. So this will produce a nice circadian phase advance. So you guys probably know already, our governing body is the American Academy of Sleep Medicine, and they help us assimilate all the amazing sleep research that's out there to make recommendations on treatment. Dr. Shelgekar is our governing body's president, which is really cool right now. So if you have any complaints, just go to her. But this was an update in 2015 for the treatment of the circadian rhythm sleep-wake disorders. So they looked at all the research on treating these disorders and what was recommended based on that research for adults and children and adolescents. Strategically timed melatonin is recommended for the treatment of delayed sleep-wake phase disorder. It doesn't matter if you have depression or other comorbid psychiatric conditions in children and adolescents. And you can see here that the studies tried a variety of different doses, which we'll talk about in a moment, and different timing, again, whether it was reference to DILMO or whether it was reference to clock time. Post-awakening light treatment alongside behavioral treatment is only recommended in children and adolescents. Why? I just showed you all about this stuff about how light can shift circadian phase. It's not that light is not effective in adults with delayed sleep-wake phase disorder. It's that there's insufficient evidence. And when they make these recommendations, it's kind of like up to date. They have to assimilate what's available, and they make recommendations based on this. So even though it's not recommended, it is likely effective. Light and melatonin together might augment the impact as compared to one or the other, and also adding timed light avoidance. So avoiding light in the part of the phase response curve where light would produce a circadian phase delay. So in the evening or nighttime for most people prior to core body temperature minimum. However, again, these weren't included because of the amount of evidence. Okay, so how much melatonin do we give, and how do we know when to give it? So a lot of investigations have looked at timing of melatonin. The two ones that are often referenced are Monday et al. In 2005 and Burgess et al. In 2010. So this is from Northwestern, and they tried both 0.3 and 3 milligrams of melatonin. They measured dim light melatonin onset, right? We don't have that luxury, so we're going to estimate DILMO at 2 hours before natural fall asleep time. And they tried melatonin at 6.5 hours before DILMO or 1.5 hours before. And they found that you got a bigger circadian phase advance with 6.5 hours prior to dim light melatonin onset. That Mundy study, like we said, also tried 0.3 and 3 milligram doses. So this graph here, this is just a graph regarding correlation. This is just your lines here in the R-squared slope. So on the y-axis, you have the amount of phase shift, right? And bigger is better, right? We want to produce a nice large phase shift to phase advance these individuals with delayed sleep-wake phase disorder. And then the x-axis here is the time of melatonin administration when these people dose their melatonin, operationalized in hours prior to DILMO, right? So everywhere from 1 hour before DILMO, and then this is 7 hours before DILMO, but they went to a maximum of 6.5. So what you can see is at the earlier times, there are larger circadian phase advances. The slope of these two lines was not significantly different, so meaning that the 0.3 and 3 milligram doses of melatonin produced equivalent circadian phase advances. The lower dose, however, particularly when we're giving melatonin so much earlier than when people are ready to fall asleep, with the lower doses, you have less of that soporific or sleepiness effect of the melatonin, and you don't lose any of the phase shifting properties. So that's why we typically talk about 0.3 and 0.5 or no more than 1 milligram when we talk about circadian phase shifting. So kind of going alongside with that, there was an excellent study that was done here to say, okay, if we know that phase shifting is dependent on the dosing of melatonin relative, the timing of melatonin dosing relative to dim light melatonin onset, does measuring the DILMO improve outcomes above estimating the DILMO? Okay, so this was Dr. Swanson, and then you probably recognize a lot of names because this was done here. And they looked at 4 weeks of treatment. The melatonin dose was 0.5 milligrams, and they randomized these individuals to 2 different arms. They either measured their DILMO to determine the dosing and dosed it 3 hours before their measured DILMO, or they estimated DILMO, right? And so it was estimated at 2 hours before natural fall asleep time, and they timed the melatonin 3 hours before that. 3 hours plus 2 hours before natural fall asleep time is 5 hours before the natural fall asleep time that the melatonin was timed. They moved the melatonin and the sleep-wake scheduling an hour earlier each week, and you'll see me recommend that in clinic. You can move the circadian clock faster than that, but I find that this works well as far as adherence. And at the end of this 4 weeks of treatment, a 90-minute advance was seen in circadian phase. They measured DILMO at the end, sleep onset, and sleep offset. So there was no difference between whether you timed melatonin based on actual true direct measurement of melatonin or estimation of melatonin onset based on sleep time that was measured with actigraphy. There was improvements in fatigue, sleep disturbances, sleep-related impact scales, but these were also similar between the measured and estimated dim light melatonin onset groups. And there was no improvement in either group, interesting, in sleep quality or total sleep time. So at least from this investigation, it appears that we do pretty well just with estimated dim light melatonin onset to time our dosing of melatonin. Okay, Rebecca, I'm going to have you read this case.
72-year-old male comes to your clinic for evening sleepiness and inability to remain asleep throughout the early morning hours since moving in with his son's family 6 months ago and trying to stay on their schedule. When living on his own, he had no problem with sleep. You obtain actigraphy.
All right. So what do you guys think is going on based on this actigraphy? So this is 1800 here, so 6 p.m. This is 6 a.m. Remember, the taller the line, the more the activity, the lower the line, the less the activity, likely presumed sleep. And then each of these panels represents a day.
It looks advanced.
Exactly right. Advanced sleep wake phase disorder. You have this other clue here of when living on his own, he had no problems with sleep. Good. What time is the estimated dim light melatonin onset, and when should light therapy begin? And I'll let you guys kind of unmute and say your answers. So it looks like his natural sleep onset here occurs between 1900 and 2000. So between 7 p.m. and 8 p.m. So when does Dilmo start, and when should we get him light therapy?
So does Dilmo start at 5 p.m. and then we should start light therapy at that time?
Yes,
Okay.
very good. Okay, so let's walk through this. So we know this gentleman, like we said, he's falling asleep at 1900 to 2000, 7 to 8 p.m. So his estimated Dilmo is going to be around 1700 to 1800, so 5 p.m. to 6 p.m. So just like the sleep-wake timing is advanced in advanced sleep-wake phase disorder, the circadian phase is expected to be advanced as well. So in advanced sleep-wake phase disorder, to move the endogenous clock later, we need to pursue a circadian phase delay. So we're going to go back to our phase response curve to light. So we're looking at the range of times where light is going to produce a circadian phase delay. And that's going to start about 4 hours prior to the natural fall asleep time. And it's going to continue on to the first 2/3 of the natural sleep period, with the crossover point being at the time of the core body temperature minimum. Yes, Brad.
Do you have a recommended light source, like brand or something like that?
Yep.
I know you said 10,000 lux, but
So
I guess-
10,000, yep. So anywhere between 2,500 and 10,000 lux has been investigated. There is, because I get asked this a lot by patients, and I don't like recommending certain brands, but there's a website, and it's called, I should have put it in the slides, it's www.CET, so Center for Environmental Therapeutics. And it's run by 2 circadian researchers, and they have products there that are like sort of vetted. And so I often send my patients there, and then they go there. Sometimes they get stuff that's recommended there, or they'll find similar specs on Amazon and they'll get that. But you're looking for full spectrum light, 10,000 lux. Like you learned with Dr. Hirschner, the circadian timekeeping system is most sensitive to short wavelength light, like 460, 480 nanometers blue light, because the melanopsin in the intrinsically photosensitive retinal ganglion cells, melanopsin is peak absorption is at 460 to 480. However, we find that full spectrum light really does the job. There's no benefit to just giving people blue light, believe it or not, in most studies. Yes, Paul.
So I was wondering, is there a seasonality to this as well? Like, I guess, does like the winter months with the earlier sunset affect kind of the advanced or delayed?
Yeah. So you would think, I haven't seen much work on that, but I mean, so there's also thought to be like the pathophysiology behind these disorders. Like there's some concern that people who are delayed are more sensitive to light at night. So when we do go through that spring transition and the clocks change, they could be more vulnerable to undergo a circadian phase delay because it stays so light so late. So it's possible. It doesn't seem to have been that well studied. All right, so you guys are correct. So in this individual, because his dim light melatonin onset is around 1600 to 1700, and his natural sleep offset times around 4 a.m., a circadian phase delay will be produced by light between 1600 and 1 a.m. So D is the correct answer. Very good. And if we go and look at our practice parameters, they do make a recommendation for evening light therapy to treat adult advanced sleep-wake phase patients. And that's based on a study that used 4,000 lux white light versus a dim red control. And they gave the white light for 2 hours between 2000 and 2300. Again, you really need to estimate circadian phase based on your patient's habitual sleep time. What they found is that light at this time produced a circadian phase delay as measured by core body temperature minimum, which was pushed more than 2 hours later, and total sleep time increased by almost an hour. Okay, great. Now Paul is at the top of my screen for some reason. So Paul, I'm going to have you read this question.
Sounds good. Which statement best describes treatment of irregular sleep-wake rhythm disorder in children and adolescents? A, melatonin is contraindicated when ISWRD is comorbid with autism. B, the melatonin the hour before bedtime may be considered for treatment of ISWRD in children and adolescents with neurologic disorders. C, melatonin may be considered for treatment of ISWRD in children and adolescents with neurological disorders. However, this is only in the context of multimodal therapy with bright light. Or D, melatonin improves sleep ratings by caregivers, but not objectively recorded total sleep time.
All right, what do you guys think the answer is here?
I don't know, but I'm going to take a guess and say D.
So the correct answer here is B. So melatonin, the hour before bedtime, is recommended for treatment of irregular sleep-wake rhythm disorder in children and adolescents with neurological disorders. A is incorrect because it has been evaluated in autism without serious adverse events. C is incorrect because it is effective as a standalone treatment without bright light. And D is incorrect because both subjective and objective total sleep time has been shown to improve based on the research. So going to our practice parameter, strategically timed melatonin is recommended for children and adolescents with neurological disorders. In the work that's been done, giving melatonin an hour before bedtime increased total sleep time both by actigraphy recording and parental report, and this included individuals with neurological disorders such as autism. Okay, and now I have Brad, will you read this question?
In regards to an elderly patient with dementia and ISWRD, which of the following treatment options should be considered? White broad spectrum light therapy at 4,000 lux for 2 hours at 9 a.m., doxepin 3 milligrams at bedtime, melatonin 1 milligram 2 hours before habitual bedtime, melatonin 1 milligram 5 hours prior to habitual bedtime in conjunction with white spectrum light therapy at 4,000 lux.
All right, what do you guys think the answer is here? Okay, so we'll go through this one. The correct answer is A. The reason the correct answer is A is so, as you can imagine, melatonin has been evaluated in elderly people. And as far as what was analyzed for the practice parameter, these individuals didn't necessarily have a regular sleep-wake rhythm disorder, but the studies were on institutionalized dementia patients who had sleep-wake disturbances. And there were 2 randomized controlled trials, and it was found that light between 2,500 and 5,000 lux, 1 to 2 hours in the morning, 9 to 11 a.m., decreased wandering, improved violent behavior, restlessness, and delirium, and improved sleep. However, melatonin, there was some improvement in sleep, but not across the board, and there appeared to be a negative impact on mood and function. So in the elderly with dementia, there is a recommendation for light, but against melatonin, even if you do multimodal therapy with light, and then obviously strong against hypnotics in individuals who are demented and elderly because of the risk there. You'll still see a lot of melatonin use in demented patients with sleep disturbances, just based on the fact is that there's limited tools. And the implementation of light in the morning, as you can imagine, could be difficult in institutionalized adults if you don't have buy-in from the institution. But this is what the data recommends. And so, let me go.
Quick question. So is that so elderly and dementia or just because
Elderly
it's
and demented.
okay, so
That's what was-
elderly is a different
Well,
It's
that's
like-
what was studied, right? So we
Yeah.
they can only make recommendations in what was studied, right? And it's the dementia patients that are the ones that typically have irregular sleep-wake rhythm disorder, not just elderly, because it's an irregular sleep-wake rhythm disorder is pretty uncommon. But there's some thought that the neurodegeneration also affects the SCN, and that's why it's seen in demented individuals. And so that's why your B, C, and D are incorrect here. Okay, good. Okay, so now I have Naya. I will have you read this question.
The sleep diaries of a 36-year-old male with no past medical history with intermittent insomnia and excessive daytime sleepiness are plotted below. What do the filled and empty circles most likely represent? And then A, melatonin,
have
one
to go.
Okay, thanks.
So let's look at the picture first. So this is sleep diaries that are digitally plotted here. So you have your days, and then you have, this is something called double plotting. So you have noon to noon, and then noon to noon, and you have repetition of the previous day on the second line. And this double plotting is nice because it gives you a better kind of visual representation of the pattern of sleep timing. So what do we think this individual most likely has as far as their circadian rhythm sleep-wake disorder?
Non-24.
Yep, non-24-hour sleep-wake rhythm disorder, because we see an iterative delay of the sleep-wake timing. This individual has no past medical history, so we'll make the assumption that he does not have blindness. So what do we think the dark circles and the open circles here likely represent? So we can see that during the period where the dark circles and open circles are, that the patient is entrained to the 24-hour day.
I'm going to say B, the melatonin, 1 milligram for dark, and then the light.
Correct, exactly right. So what they did is they waited till this individual's sleep, their natural tendency for sleep aligned with the nighttime period. They dosed melatonin probably 1 to 2 hours before to kind of stabilize that. And then they gave them light at the end of the sleep period to make sure that there was not an iterative phase delay, and that entrained the circadian phase. And so the correct answer is B. Very good. Now, that was an individual who was cited, that's from a case series, I believe, in 2018 of cited individuals with non-24-hour sleep-wake rhythm disorder. However, at least at the time of the practice parameter, there was not enough evidence to make any recommendations in cited individuals. So we only have recommendation in blind adults, which the recommendation is strategically timed melatonin. And that is based on the meta-analysis of 3 different studies. So from Hack, Lockley, and Sack, which tried 0.5, 5, and 10 milligrams of melatonin. These timed it at 9 p.m. This one was 1 hour before preferred bedtime. You can see the forest plot here, and the outcome is odds of entrainment to the 24-hour day. So remaining stable, and the sleep period aligning with the nighttime period instead of that iterative delay is entrainment to a 24-hour day. And we can see that these studies favored melatonin. And so that's why this was recommended. Okay, so you guys, have you heard of Hetlioz or Tasmelteon? So Tasmelteon, or the brand name Hetlioz, is a dual melatonin receptor agonist, right? So if you want to use an FDA approved drug, and it has been tested in totally blind individuals with non-24-hour sleep-wake rhythm disorder. They gave them tasimelteon 20 an hour before the desired bedtime. They did 2 studies, set and reset. This was published in Lancet, so it's really good, right? So, and the outcome again was this entrainment to the 24-hour day. 20% of individuals in the tasimelteon group entrained, as opposed to 3% of individuals in the placebo group. 24% showed a clinical response on this non-24-hour scale, and 0% showed a response in the placebo group. And they said that this difference of clinical responses, as you can see here, is statistically significant. Then in the reset trial, the second study, they took people off the tasimelteon to determine if they would stay entrained. So only 20% that went on placebo remained entrained, and those who continued tasimelteon, 90% of them remained entrained. Wow, awesome, super effective medication. Why am I telling you this? Okay, so I updated this slide today. 30 days of tasimelteon, 20 milligrams, right? That's what was used in the study. And you say you have to stay on it, right? Because you go off of it, you start free running again. It is anywhere between $6,000, I don't know how Walgreens gets it so cheap, and $25,000 a month. That is crazy. It's so funny. They don't like change their branding or the UI on the website, right? So it's like, look, with a coupon, it's $9,999. I don't know. I found that kind of funny.
It's so ridiculous, Kathy. So I have a patient, or had a patient on this, and she couldn't get her prior authorization because she had a little bit of light perception. She was blind. She could just perceive light. And insurance didn't want to cover it because of that.
Yeah. And I think anecdotally, even so, obviously our gold standard is the randomized controlled trial, but Dr. Hirschner will also tell you this. Anecdotally, there have been some cases where people couldn't entrain with melatonin and they did entrain with this medication. But obviously, as you guys can tell, there's a lot of limitations to using this. Okay, so great. B is the correct answer. Okay, so I made these because I'll give you guys this talk in like a PDF, and I wanted you to have these little slides you can go back to, whether it's in clinic or you're studying for your boards or whatever. So I had these high yield pointers. So always remember your estimated phase relationships to sleep. Oh, go ahead, Abby. Oh, you're muted. Abby's saying
Oh,
that
sorry. Oh, sorry.
to
Yeah, I just had a hard time finding the raise hand sign. Did they ever look at Ramelteon in this situation as well?
Yeah, not that I'm aware of for non-24. They've looked at Ramelteon for simulated jet lag. We know that Ramelteon can phase advance the clock, and I think it would be reasonable to try.
Got it. Thanks.
It's difficult with circadian rhythm sleep-wake disorders because they are considered relatively uncommon, and delayed sleep-wake phase disorder really isn't uncommon, but we don't see as much interest in them as far as research. And also the research is really difficult to do, right? Because there's so many factors, isolating people from time givers, separating sleep from circadian phase. So unfortunately, I think Ramelteon sounds completely reasonable, but I haven't seen a lot of work there for the endogenous circadian rhythm sleep-wake disorders, but they have done simulated jet lag with it. Okay, so always remember your objective circadian phase relationships to sleep. Dim light melatonin onset is going to occur 2 hours prior to habitual sleep onset, to your natural fall asleep time. Core body temperature minimum is 2 to 3 hours before your habitual sleep offset or natural wake up time. Phase shifting is not dependent on clock time. It's depending on the biological timing of your exposure to the circadian time givers, Zygabers, light, and melatonin. Phase response curve to light exposure that occurs before the core body temperature minimum is going to produce a circadian phase delay or make the endogenous clock later in reference to the 24-hour day. Light exposure after the core body temperature minimum in the hours that follow is going to produce a circadian phase advance or move the biological clock earlier in reference to the 24-hour day. The magnitude of circadian phase delay is going to be greatest after your body's melatonin secretion has begun. The magnitude of phase advance is going to be greatest right before and a few hours after your natural wake-up time. Phase shifting may be impacted by lux, so the strength of the light, but that's not a linear relationship. Duration, the longer the exposure, the better. And then wavelength, given the sensitivity of the intrinsically photosensitive retinal ganglion cells to short wavelength light, although keep in mind that that is what's included in sunlight and in a full spectrum light box. Phase response curve to melatonin, exogenous melatonin is going to produce a circadian phase advance when it's given prior to your body's own dim light melatonin onset. Melatonin is going to produce a circadian phase delay when you give it after your body's own dim light melatonin onset. The greatest magnitude of circadian phase advance is going to occur a few hours prior to DILMO, so about 3 hours prior to DILMO or 5 hours prior to natural fall asleep time, and a few hours after your core body temperature minimum for producing a circadian phase delay, because it's when melatonin is absent, right? So melatonin doesn't work well for producing sleep or circadian phase shift when it's being secreted. Lower doses are thought to be more effective because they allow us to kind of target the correct portion of the phase response curve to melatonin, as opposed to higher doses, which might produce supraphysiological serum levels that kind of bleed into the wrong portion of the PRC. ASM treatment guidelines: advanced sleep-wake phase disorder, evening light, delayed sleep-wake phase disorder for all ages, strategically timed melatonin for kids and adults, post-awakening light and behavioral, non-24 sleep-wake disorder, only blind recommendation, and that's strategically timed melatonin, irregular sleep-wake rhythm disorder, if it's elderly with dementia, yes to light, no to melatonin, and no to hypnotics. Kids with neurological disorders, however, yes to melatonin. All right, and here's some resources. So we're now on our 3rd edition with the text revision of the ICSD. This is a nice review on circadian rhythm sleep-wake disorders from Lancet from 2022. And we have our practice parameter. And then up to date, we now have a circadian rhythm disorder section of up to date that has all the disorders. And we keep this very updated, so you can always go to up to date now. All right, we have 3 minutes for questions too. That's like really good for me.
I had a question. So correct me if I'm wrong, but normally when I'm reading these question stems about a circadian rhythm disorder, or even when I see patients in the clinic, the delayed phase patients tend to be younger, high school, and like 20-year-olds, early 20s. And then when I see these advanced early LARCs, they tend to be elderly patients. I also understand that endogenous melatonin secretion goes down as we age. Is that just a correlation? Is that why the older people have a propensity to develop advanced phase?
So what more recent data has shown in the elderly is the advance in sleep timing is actually not circadian. It actually has to do more with the homeostatic regulation of sleep.
Ah, okay.
In adolescence, you are correct. Delayed sleep-wake phase is going to be more common in adolescents and young people. We do see it persist into adulthood. But even just going through the change during puberty, we do see a circadian phase delay, even if you don't develop like frank delayed sleep-wake phase disorder. There's thought to be an objective phase delay. There's thought to be a lengthening of the circadian tau. There's thought to be a decrease in the homeostatic sleep drive buildup. And all of those things are going to result in later timing of the sleep-wake period.
Thank you.
Okay. Xinhang?
Yeah, thanks, Kathy, for a nice review. So I had a question regarding the timed melatonin for children with neurologic issues. So when they said 1 hour before bedtime, was it habitual bedtime or desired bedtime?
I don't know. I don't know the answer for that. You'd have to go back. I suspect there's some degree, because I suspect it's desired bedtime, or when these are really like developmentally delayed children. And I think it's I think the sleep scheduling is potentially driven by the caregiver. But that's a good question for, do any of our peds people here know the answer to that? Was it desired or habitual with the? And with a well, it's, you know what, Zinhang, it's a regular sleep-wake rhythm disorder that recommendation is made. So it's likely desired, since they don't really have a habitual sleep time if you have a regular sleep-wake rhythm disorder, because the sleep is so irregular, right?
Makes sense, makes sense.
Yeah.
Great, thank you.
Faye?
Hey, Kathy. Hi, everyone. Great lecture. Thank you so much. I had a question regarding the non-24. So I have a sighted individual with non-24, and I've been using melatonin for a few months now, and I haven't had any success. So I've been trying to convince him to be a little bit more strict about taking it at, the correct time and so on. But he's really kind of becoming a little anxious and telling me that he wants to try something else. So I was considering correct me if I'm wrong on how to say this, the Tasmeltion, and
Tasmeltion.
yeah, sorry. And so he is, now that you're talking a little bit about how most of the studies are in non-sighted individuals and that it's so costly, what other choices do we have? Because I'm kind of stuck at this point, and he's constantly kind of struggling. It's been over a year with this issue. So
Are you regulating his light environment as well? So
well, yeah, we're trying at least.
yeah, so the good thing about the sighted non-24-hour individuals is they have full exposure to light, right? So they can use light blocking with amber glasses and then light exposure, which is going to be a stronger Zeitgeber than melatonin in general to shift the clock. It's hard though. I found these individuals, I've heard and this is anecdotal, we don't have great data on this. I found these individuals say, I can't tolerate light during the day. I'm always in sunglasses. I don't want light. And I need to get my work done at night. So I'm in front of a screen. So, you could try prescribing Tasmeltion and going through a peer review process. If you get it approved, it'd be amazing. There is a case that was published in JCSM. They actually have the CPAP data on a sighted non-24-hour, and you can see it really nicely on the CPAP data. And they weren't able to get him to entrain with melatonin, but they were able to get him to entrain with Tasmeltion. It's just getting the medication.
Okay, that makes sense. Yeah, because right now we're kind of at a point where we've tried melatonin for so long, and we are trying to modify his light exposure because he doesn't have any blinds in his room, and he's really resistant to getting blinds. But I think that I'll continue to work with him. I'll try to prescribe it, but if it's not necessarily covered, I'm kind of stuck. But thank you, I appreciate it.
The other thing you can do, this is like an incremental change, but we don't really melatonin supplements. We don't really know how much is in them because they're not regulated by the FDA. And there's been some work that showed that the actual amount of melatonin, when they assay it, it can vary up to 400%. So the melatonin that I tend to use in my patients is the same melatonin that they use in the circadian lab here, which is the brand Natrol. So you could always try switching to a different formulation, lowering the dose to 0.5 or 0.3 if possible too.
I'll definitely try that. Thank you.
All right, great questions. Let me look in the chat here really quick before we go. Okay, so Lisa says, yes, it is desired bedtime with the kids with neurological disability and irregular sleep-wake rhythm disorder, which makes sense. Okay. Oh, and Paul put the CET website in the chat too. All right, thanks guys. I'm sorry I look terrible and I'm kind of out of it, but.
No, you don't. Thank you.
You did great.
I have a big guy, but all right. Thanks guys, bye.
Thank you.